Assalamu alaikum everyone. My name is Salma Metwally. I'm a fourth year medical student, and today, inshallah, we will be discussing all of the MSI block microbiology. This covers the musculoskeletal and rheumatology parts. Okay, so we'll talk about septic arthritis and osteomyelitis, and then all of the infections of the skin, including bacterial, viral, fungal, and parasitic. Starting with septic arthritis, let's break down the term. We have septic and we have arthritis. When we say arthritis, it's inflammation in the joint. And the word septic means infectious. You know, when you say antiseptic, you are saying that you want to get rid of infection, right? So antiseptic is getting rid of infection, septic is infection itself. So this is an infection inside the joint cavity leading to joint inflammation. Now, something that you have to keep in mind is that the joint is a sterile organ. And what this means is that normally the joint does not have any microorganisms inside, okay? It has no bacteria, nothing. It's absolutely sterile. And this point will be significant in a couple slides. We'll come back to it. Just keep it in mind, okay? Now, how does septic arthritis even happen? What is the pathogenesis? We have four main mechanisms. And the most important one, the most common one that you have to know is the hematogenous route. Now, the four mechanisms. First one is hematogenous route. Basically, this is a joint cavity, and you have the blood vessels that are going to go into the joint and feed the joint, okay? If you have an infection somewhere in the body, like somewhere completely different, not even nearby, let's say someone has infective endocarditis, which is infection in the heart valves, they have an infection there. Pieces of the infection with bacteria are gonna seed into the blood, and then they're gonna move through the blood and eventually reaching the joint. Okay, so they just seed from somewhere completely different in the body, reaching the joint. So for that, you need bacteremia. You need to have bacteria in the blood in order for it to reach here. And this hematogenous route through blood is the most common way by which we get septic arthritis. Okay. Now, the three other mechanisms are if someone has a nearby infection, let's say they have osteomyelitis, which is infection inside their bone, or they have cellulitis, which is infection in the skin that's overlying the joint. Okay, this nearby infection will just directly move into the joint. Okay, this is not the same as the hematogenous one. Hematogenous is you have bacteria in the blood going to the joint, but these are just infection nearby that's just directly spreading into the joint. Okay. And then we also have iatrogenic. So let's say someone is getting fluid out of the joint for fluid analysis, or someone is getting an injection of steroid or whatever. This needle could be infected or contaminated. It could be not sterile. So if it's not sterilized properly, it can introduce infection inside the joint. This is another way by which someone can get septic arthritis. And finally, there is trauma. So if someone has a penetrating trauma to their knee, for example, like this picture here, and they get like a tree branch that, they got into a road traffic accident and they have something puncturing their skin going into their joint. This introduces a foreign body inside the joint, leading to infection. Okay, so we said four ways: hematogenous, contiguous, which is just from a nearby, like osteomyelitis or cellulitis, traumatic from, the puncture wound, and iatrogenic from something that's not sterile. And hematogenous, which has bacteremia, is the most common way by which someone gets septic arthritis. Now, when the bacteria reaches into the joint, it's gonna attach to the joint surface, to the bone surface and the cartilage surface inside the joint. When it attaches there, it's going to start to release all of its enzymes and toxins, and this induces an inflammatory reaction inside the joint. And when there's inflammation in the joint, you know all the hallmark features of inflammation. There's redness, swelling, all of that. The important part is edema, okay? You have a lot of edema and a lot of fluid, as well as the pus that's forming inside the joint because there is bacteria, okay? All of this fluid and pus fills the pressure inside the joint, leading to ischemia. And when there's ischemia inside the joint due to the pus accumulation, this is what gives the very severe pain, okay? So bacteria adheres to the joint surface, there's enzymes and toxins being released, there's an inflammation, and ischemia due to the pus. Do you need to know all of these things that are written here? I don't think so, in my opinion. Just there will be another virulence factor in a few slides that you should know. These ones, if you want to just know like what they look like, I wouldn't recommend wasting brain power on them. But just know the mechanism. There's adhesion, there's release of enzymes and toxins and inflammation, and then ischemia. All right. Now, back to this point, the joint is a sterile organ. We said that this is significant, and we said that normally there is no bacteria inside. Why is this significant? Because in order for someone to get septic arthritis, they have to have some risk factors, okay? Someone who's completely healthy, have a healthy joint, are very unlikely to just magically get an infection in their joint, okay? They have to have some risk factors. The most important, the primary risk factor for getting septic arthritis is having a pre-existing disease in the joint. So someone who has rheumatoid arthritis, for example, or osteoarthritis, or someone who had surgery in their joint. The joint surface is not healthy, it's rough and it's not smooth like it normally should be. This rough surface makes it easier for the bacteria to stick on the joint and cause infection. And the most common one that's associated with septic arthritis is rheumatoid arthritis. But just know any disease in the joint makes someone more likely to get septic arthritis. Another thing is a chronic breach in the skin integrity. And this is true for any infection in general. If someone has, let's say, a diabetic ulcer, okay, someone who's diabetic and they have an ulcer on their foot, and you know that in diabetes they have neuropathy, so this makes them unlike they don't feel the pain in their ulcer, so the ulcer stays for a long time. The chronic ulcer gives you a breach in the skin. Bacteria can enter through this ulcer. It's like a door for the bacteria. Eventually, they can reach into the joint. Other things are chronic skin conditions. If someone has psoriasis, the skin is not intact, it's not healthy, they're more likely to get an infection that can reach their joint. And also IV drug abusers, because they put needles through their skin and they're constantly introducing things into their blood, as well as having just open wounds on their skin from the needles. And finally, someone who's immunocompromised. Now, immunocompromised people are, they're susceptible to any kind of infection in general. One of those infections is septic arthritis. Immunocompromised patients include malignancy patients, if they're taking chemotherapy, taking steroids, AIDS patients, and patients with chronic disease. All right. So the main risk factor that you should know is having a disease in the joint. Okay. Now, for the next few slides, I'm going to show you a picture, and the picture is affecting a specific joint, and I want you to correlate it with the specific underlying condition. So if I tell you this patient has septic arthritis in their sternoclavicular joint, what risk factor does this patient most likely have? I'll give you a couple seconds to think. Okay, so the sternoclavicular joint septic arthritis is a very classic picture for IV drug abusers. Just know it. It's an important correlation. They can get you a question of someone who is an IV drug abuser, or they have needle track markings on their arm, and then they tell you that, they have an infection somewhere in a joint somewhere. Which joint is most likely affected? It would be sternoclavicular, or another one, which we will see in a couple slides, is the sacroiliac joint. Or they can get you a patient who has infection in their sternoclavicular joint, like this one, and tell you what is this patient most likely, which risk factor does he have? Probably IV drug abuser. Okay, next. So this patient has septic arthritis in their knuckle, in the joints of the hand. The most likely underlying condition that's associated with this is someone who's a fist fighter or someone who's had an animal bite. So fist fighter, they, if they get an injury to their hand, to their skin, and to their knuckles, they're more likely, because they have a breach and their joints are now injured, so they're more likely to get infection. As well as from an animal bite, if it gets infected, it can spread into the joint. Now, this patient has septic arthritis in the knee. Is it most likely to be an adult or a child? Knee septic arthritis is more in which age group? The knee mostly is affected in an adult. As we will see in the next slide, children are mostly affected in their hip joint, while adults in the knee joint. Just know the association, which is more common in which. And then, as we said, in IV drug abusers, you want to be suspicious about the sternoclavicular as well as the sacroiliac joints. And for fist fighters and animal bite infections, you want to be suspicious for the hand joints. Okay. Now, what are the signs and symptoms? As you know, this is an inflammation and infection, so you're going to have all the cardinal signs of inflammation. There's going to be pain, swelling, redness, and also signs of infection like fever and chills. In most cases, it's going to be acute and very intense pain. And something that is very characteristic is that they have loss or restricted motion. This is also one of the cardinal signs of inflammation. But in septic arthritis, it's a very key sign because it means that they have something very serious in their joint. And some of the clinical doctors love asking about this. I remember like Dr. Suhaibani, like, is not micro, but in clinical, he really emphasized this point for some reason. So you should probably know it, that you have profound loss of function. Like their joint, they can't barely move it. They can't walk on it, okay, if it's the knee, for example. So signs of inflammation as well as very severe acute pain. Now, when we are talking about septic arthritis and we're discussing the organisms that cause it, we can have bacterial septic arthritis versus other microbes, like fungi, viruses, but we won't really discuss these today. We're gonna discuss bacteria. That's the more common cause of septic arthritis in general, bacterial septic arthritis. Inside the bacterial septic arthritis, we divide it into categories. We have mycobacterial septic arthritis, gonococcal arthritis, and then non-gonococcal arthritis, which includes all other bacteria. And these are in very specific groups of patients. The non-gonococcal are the more general and classic picture, okay? Now, let's just differentiate the two big categories. For mycobacteria, it's just TB, and someone who has a disseminated TB infection and they have septic arthritis, you want to suspect TB, especially if it's the vertebral joints. We're gonna see it in a few slides. So we'll just keep this on the side for now. We'll focus on the non-gonococcal versus gonococcal. Gonococcal, gonococcal is gonorrhea, Neisseria gonorrhea, and it's an STI, sexually transmitted infection. So you would see it in someone who's young and sexually active, and more commonly in a female. And the reason for that is gonorrhea infection in a male is a lot more obvious. Okay, they would have very clear discharge, and this male patient would be, worried about it. They would go seek treatment for it, and they're less likely to develop into this severe form of gonococcus, getting arthritis. But the female, these symptoms are less obvious. So this patient might not even know that she has gonorrhea infection, and it reaches a point where it becomes disseminated. So instead of just being an STI localized, it's going to spread through the whole body. So when it does, they will get arthritis. We call it migratory polyarthritis because, as we just said, it spreads to the whole body, so it can affect multiple joints. And when it does, we call it migratory polyarthritis because it can affect the knee one time and then it moves to their hip and then it moves to the shoulder. So it keeps affecting different joints at different times. And other than the arthritis, they can get dermatitis and tenosynovitis. Just think about it like the infection is disseminated throughout the whole body, so it can affect a lot of joints and can cause other symptoms other than the arthritis. For the non-gonococcal arthritis, this would be the more classic type. You would see it in someone with risk factors, as we said. So someone who has a predisposing condition like a joint disease or someone who's immunocompromised. It's also more commonly seen in newborns or elderly because they tend to have a weaker immune system. And the non-gonococcal arthritis usually only affects one joint. So because it's just the classic like septic arthritis, one joint, but in gonococcal, it's disseminated, multiple joints, right? Now, something that you really have to drill into your mind and just know as your name is that the most common cause of septic arthritis is Staph aureus. This is a very key point during this lecture, and you will see that a lot of the infections in this lecture in general, both of the musculoskeletal and dermatology, you will see septic arthritis a lot, okay? But for Staph aureus and osteomyelitis, for both of those, the most common cause is Staph aureus. You have to memorize this. The most common cause of septic arthritis is Staph aureus. But before we get into the rest of the organisms, if any of you watch Sketchy for Staph aureus, you would know this camel over here. They have the little thingy, the bandages on his knees for septic arthritis. And there are also these fish for osteomyelitis. So just to remind you that Staph aureus is related to both of these, septic arthritis and osteomyelitis. Now, other than Staph aureus, we have other organisms that are not more common than Staph aureus, but they are very important for you to keep in your differential, especially in specific patient groups. So in a neonate, we really have to suspect Strep agalactia or group B strep, because as you know, This is found in a lot of women in their vaginal microbiota, and when the baby is getting born, they can get the infection through the birth canal, and especially if the mother does not take antibiotics before delivery. So, and also, if you remember from your POD, you know that group B strep causes neonatal sepsis. So, if it causes sepsis in a baby, a newborn, we said that the most common way of getting septic arthritis is having bacteremia, which is bacteria in the blood. So, sepsis. So, if a neonatal sepsis due to GBS puts this baby at risk of getting septic arthritis. Okay. And we said that Staph aureus is the most common in children and adults in general. Then for sexually active adults, you still have Staph aureus as the most common cause, but you also want to suspect Neisseria gonorrhea. You should have it in your differential, especially if it's disseminated and affecting multiple joints. For prosthetic joints, you want to suspect Staph epidermidis. Again, Staph aureus is still there as your top differential, but Staph epidermidis is very important to know for the prosthetic joints. You can also have any other skin microbiota, but very important for you to remember Staph epidermidis. For IV drug users, Staph aureus is the most common again, but you also consider some gram negatives like Pseudomonas. And these are very important because they can get you in any of these case scenarios and ask you about the most common or the most likely infection. If they ask you the most common organism, the most common, if you see Staph aureus, then this is the answer. But if they tell you which infection, which organism is important to keep in mind for this, you would choose any of the other ones. Okay? I know it's confusing, but we'll make it clear in a few slides, inshallah. For diagnosing septic arthritis, you have some non-specific tests, which are CBC, ESR, CRP, imaging. These are all non-specific. They just tell you that you have an inflammation, but you don't exactly know what kind of inflammation it is. So you do two things. You do blood culture and you do joint fluid analysis. And you do both of these before you start antibiotics. Because if you give antibiotics, you're going to kill the bacteria, and your blood culture or your joint fluid analysis can be falsely negative. So you want to take those samples and then start antibiotics straight away. So blood culture, why? Because we said that the most common way is hematogenous. So you're probably going to have some bacteria in the blood. So blood culture is important. And then joint fluid analysis, obviously, you want to look at the joint fluid to see if it's infected. And what you're going to see is the appearance of this joint fluid is going to be more opaque or purulent compared to the normal transparent color. It's going to be more yellow, green. So it's just think of pus and imagine the fluid as having a lot of pus and being yellow and green and all signs of bacterial infection. You're also going to have a lot of white blood cells because there's inflammation and infection going on. And most of those white blood cells are going to be neutrophils because this is an acute infection. And obviously, if you culture or do a gram stain on this fluid, you're going to get it positive usually. It depends on the infectious cause, obviously, but most of the time it's going to be positive. And obviously, in normal cases, it's negative because, as we said, the joint is sterile. Okay? The ones in yellow are the most important ones that you have to know. And when you look at this picture, comparing the different, appearance of the joint fluid in different diseases, if you look at this here, is the normal one. It's very clear and transparent. And then if you look at the one with septic arthritis, you're gonna notice some pus inside. Like, look at this. It looks like there's pus and just, it doesn't look very healthy. So this pus and this opaque appearance, you can even like here you can see the paper behind, but here you cannot. It's not transparent anymore. This is suspicious for septic arthritis. Now we are done with the septic arthritis and we're going to move to the next part, which is osteomyelitis. As we did with septic arthritis, let's break down what this means. So os is bone and myle is bone marrow. So, and itis is inflammation. So you have inflammation of the bone and bone marrow, and it's due to an infection. So you have a bacteria or some organism infecting and invading the bone, leading to inflammation. Again, as we said with the joints, bone is a sterile organ. Normally, you should not have any organisms or any bacteria inside bone. Okay, so you're gonna need also risk factors to get infection in the bone, just like we did with the joint. How does the infection even reach the bone? It's very similar to septic arthritis. Same four mechanisms. We have hematogenous spread, contiguous spread from a nearby infection like cellulitis or from septic arthritis in this case, There's also traumatic, iatrogenic, same thing that we talked about in septic arthritis. For hematogenous, I'll just emphasize one thing. If you see these vessels, the nutrient artery and vein, these are the ones feeding the bone. They go into the bone and then they reach the end at the metaphysis, and you're gonna have the capillary bed. And if you notice these sharp, like loops, these U-turns, they're very sharp, and so when the blood reaches here, it's gonna slow down a lot, like it's gonna slow down as it's turning. Just imagine if you're driving and you reach a U-turn and you want to take a U-turn while you're driving, you're obviously gonna need to slow down, okay? So you slow down as you're turning, and the blood does the same thing. And when it slows down at this loop, this slowing down gives the bacteria more time to exit the blood vessels and seed into the bone, okay? So this nature, the structure of the vessels is an important factor when it comes to how the infection comes to be. And we have three main steps in the pathogenesis of osteomyelitis. You have, obviously, after the bacteria reaches into the bone, you're going to have three main steps: inflammation, necrosis, and new bone formation. So inflammation, so we reached that the bacteria is now inside the bone. It's in the metaphysis. And when it gets there, obviously, it's going to release all of its cytokines and all the enzymes, and it's going to induce inflammation. And when there's inflammation, there's going to be pus and edema. And just like we saw in septic arthritis, all the pus and edema is going to cause ischemia. This ischemia is going to lead to bone necrosis. Okay? So you're going to get the next step, which is bone necrosis. So now you have pus leading to ischemia, killing the bone, and there's going to be dead bone inside of this infectious, like this, see this circle? This is the whole like infected area. And inside you're going to have necrotic bone because of all the ischemia. This dead bone is called sequestrum. And if you know, sequestration is like if you're just holding something and just keeping it in one area and just forming a wall around it. So the sequestrum or dead bone is just kind of forming like a barrier over here. And when you get that, the dead tissue, the dead bone, is gonna attract even more bacteria. The bacteria is gonna go there and just, you know, sit there because of this dead bone, it doesn't have blood flow. And if it doesn't have blood flow, it's not gonna have immune system. So the bacteria is just gonna go and hide in there in this dead bone, the sequestrum. Now, as a reactive process to the dead bone, the bone is gonna start to form new bone. So it's like, oh, we lost bone, let's make more bone. So now we're gonna have new bone formation. And this new bone, if you see this area here that's like forming new bone outside the normal bone structure, this is the new bone. Remember how we said that the dead bone is called sequestrum, the new bone is called involucrum, okay? So dead bone is sequestrum, new bone is involucrum. As we said, there's dead bone, so we form new bone, and this new bone is gonna wall off some pus. We have a lot of pus here, obviously, because we have infection. And the new bone, when it forms, it's gonna surround the pus, and you're gonna end up with this subperiosteal pus-filled abscess. Okay, this is a new bone. It's gonna, you know, trap all of this pus, forming some sort of abscess. So again, we have subperiosteal pus-filled abscess, we have sequestrum, which is the dead bone, and we have involucrum, which is the new bone. And if you see new bone formed in someone with osteomyelitis, that means you're now in chronic osteomyelitis. Because in order to form the new bone, you're gonna have to have this infection for a very long time. The bone does not form overnight, okay? So in someone with chronic osteomyelitis, eventually, after a long time of infection, they're gonna have new bone formation, okay? So in acute osteomyelitis, you will not see this. You will not see new bone. You will not see all of the slides, okay? None of this will be there. Now, we have to think about something in the pathophysiology when it comes to children versus adults. This, in children, since their long bones, like the femur, are still growing, they have very rich blood supply. Remember these nutrient arteries and veins, these vessels? In children, since they're still growing, they're gonna have a rich blood supply in their long bones. And if they get osteomyelitis because of the rich blood supply here, they're more likely to get the osteomyelitis in these long bones because of how much blood they have. Okay, more blood means you have more for the bacteria to seed into. Okay, so in children, osteomyelitis is more commonly seen in long bones, and it's because of the sharp loops of the vessels, as we saw, the U-turns, and causing seeding of organisms, versus adults, where you have to suspect vertebral osteomyelitis. And the reason for that is in the vertebra, they have small arteriolar vessels. Um, so you'll see, because if you look at a vertebra, you have a lot of spongy area inside. And so you have a lot of arterioles going inside the spongy area, and they're very small, so they can trap bacteria. You also have Batson's plexus. Um, and this Batson's plexus is basically a plexus of veins that does not have valves. Normally, you know that veins have valves, and the valves prevent blood from going back. So if these veins don't have valves, the blood will just remain in this area. There will be stasis and more likely for them to get infection. And I also want to just step back into something that I said in septic arthritis. When I said TB for septic arthritis and I said vertebra, I confused this with osteomyelitis. So in the septic arthritis, when you think of TB, it's not necessarily in the vertebra. It can be any joint, but since they have disseminated TB infection, it can affect that. In TB affecting the vertebra, it is the classically in osteomyelitis. Okay, so I hope I didn't confuse you, but I said vertebra and the septic arthritis TB, but the vertebra in TB is more classically as seen in the osteomyelitis. Okay, I hope that made sense. Now, back to this key point, this very high yield point, the most common cause of osteomyelitis is Staph aureus, just like septic arthritis. Okay, Staph aureus, Staph aureus, Staph aureus. Just keep it in your brain. Just, yeah, just, I don't know, drill it. I want you to see it in your dreams. Just keep it there somehow. Okay. And again, back to this picture, we said this is Staph aureus, sketchy. This, the knee is septic arthritis, and the fish bones osteomyelitis. Okay. Now, this slide is a very high yield slide. If you're gonna know one thing from the osteomyelitis lecture, make it this slide, okay? This is where a lot of questions are gonna come from. They'll give you a case scenario and ask you about the organism. So you have to know these. Like, you just have to figure out a way to just associate them with each other. So we'll talk about the classic associations in osteomyelitis. This is the point that I was referring to. Vertebral osteomyelitis is due to TB, and this has a very specific name. It's called Pott's disease. So if someone has a disseminated TB infection, and this infection affects their vertebral bones, so now they have osteomyelitis due to TB. This is called Pott's disease. Okay. The other association is if someone has prosthesis in their bone and they get osteomyelitis on top of the prosthesis, you want to suspect staph epidermidis, just like we saw in septic arthritis. Just think of epidermidis anytime you think of prosthesis, okay? Just, prosthesis equals epidermidis. You can also have Propionibacterium, which is one of the skin microbiota for prosthesis because they touch the skin, and there's the whole biofilm on top of it, if you remember from POD. So any skin microbiota can be implicated, but epidermidis is a very important association. Now, the next one is if someone has a puncture wound in their foot through a sneaker. It's a very specific association, just know it. But if you imagine someone having a puncture wound through their foot and they get osteomyelitis, you have to be very suspicious about Pseudomonas, okay? Puncture wound, Pseudomonas. Prosthesis, epidermidis. Vertebra, and someone with TB, this is Pott's disease. The next one is sickle cell anemia. Sickle cell anemia, you have to suspect Salmonella as a very important differential. You can also see strep pneumonia, but Salmonella is a more important differential. And I forgot to put the Salmonella sketchy picture, but if any of you watched it, you would remember that Salmonella has a sickle. It's carrying a sickle, and there's also the fish bone. So sickle cell anemia, Salmonella osteomyelitis. Then the next one is someone has an animal bite or a fist fighter. So for animal bite, they're all written here together, but more commonly you would see animal bite with Pasturella multicida. And the reason for that is Pasturella is part of the animal's microbiota, the oral antibiota of animals, the oral microbiota of animals, especially in cats. So if someone has a cat bite, and then they get osteomyelitis, you should be suspicious about Pasteurella multocida because it's part of the cat's oral microbiota. The next one is fist fighters, especially if someone punched someone in the face and they got, into their mouth and they broke their teeth, whatever. There's Echinella. Echinella is part of the human oral microbiota. So if someone is a fist fighter, they get in contact with another person's saliva, and this will have Echinella inside. So in a fist fighter getting osteomyelitis, you should suspect Echinella. And then you also have streptococcus and anaerobic bacteria that are important to keep in mind, also in a diabetic foot patient. But classically, Pasteurella multocida for animal bite, Echinella for fist fighter. Okay? The next two groups are someone who has fungal osteomyelitis and someone who's immunocompromised. You will see fungi here, and then you will also see fungi here in immunocompromised. Now, what's the difference? In this fungal osteomyelitis caused by Coccidioides immitis and Histoplasma capsulatum, these two are endemic fungi. So they are found in specific areas, mostly in North America and parts of the US. They are endemic there, so they can cause fungal osteomyelitis, and the person getting them does not necessarily have to be immunocompromised. It's endemic. It can affect anyone who lives in that area, okay? So these endemic osteomyelitis, endemic mycoses, are Coccidioides immitis and Histoplasma capsulatum, okay? And the next group of patients are immunocompromised patients or nosocomial infections, which are acquired inside the hospital. So someone who was sick and hospitalized and they get an infection. In these, you want to suspect gram-negative, like Enterobacteriaceae or Pseudomonas. You also want to suspect opportunistic mycoses, and these are not the same as the previous ones. Opportunistic mycoses are Candida and Aspergillus. These ones affect immunocompromised patients, like here. These ones are endemic. These ones are opportunistic for immunocompromised. For this slide, I would emphasize the ones in red. These are the commonly asked about, but any of these are important for you to know. This slide is one of the most important slides in this lecture, okay? If you're gonna know one thing, it's this slide, okay? Know it very well, all right? Now, we can also classify the organisms that cause osteomyelitis by age. So in an infant, you want to suspect group B strep or Strep agalactia. As we said, they can get neonatal sepsis from this bacteria, and it could end up causing osteomyelitis, just like we saw in septic arthritis. And for all the other ones, for children and adults, the most common is Staph aureus. Okay? Now, this question, I want you to think very well about this question. What is the most common cause of osteomyelitis in a sickle cell patient? Okay? Most common. If you said anything other than Staph aureus, you're incorrect, okay? If you said Staph aureus, good job. Staph aureus is the most common cause of osteomyelitis in a sickle cell patient. Now, you might be wondering, didn't we just say Salmonella is an important cause of osteomyelitis in these patients? And that's correct. But the idea here is that we're asking about the most common cause of osteomyelitis in sickle cell patients. The most common cause is Staph aureus. If we're talking about Salmonella, the most commonly seen group of patients in Salmonella osteomyelitis is sickle cell. Okay, what does that mean? So if we get all patients with sickle cell who have osteomyelitis and we try to identify the organism that they have, majority are going to have Staph aureus, okay? If we, in another completely different study, we get all of the patients who have Salmonella osteomyelitis specifically, okay, not just osteomyelitis, no, we get Salmonella osteomyelitis. The majority of those patients who have Salmonella osteomyelitis are gonna have sickle cell disease, okay? So the most common cause is Staph aureus, but the most common disease associated with Salmonella osteomyelitis is sickle cell patients. This is a confusing point. I hope I made it clear, but just know, try to understand the difference in associations. Okay, now how do these patients present? It makes sense to know, this is an inflammation, there's an infection, so they're gonna have all of the cardinal signs of inflammation again. They're gonna have pain, redness, erythema, redness, warmth, swelling. They're also going to have fever, chills, and it differs whether it's acute or chronic. And acute is less than 6 weeks, chronic is more than 6 weeks, so the cutoff is 6 weeks. Um, in acute, the pain and limited range of motion is going to be more profound, while in chronic, it's going to be more of a chronic pain. It's not going to be as severe and as acute and sudden as this one. Also, in acute, they may present with septic arthritis because, as we know, um, they each can be caused by each other. So you can have septic arthritis that became osteomyelitis and vice versa. So specifically in acute osteomyelitis, you may also see septic arthritis. And in chronic osteomyelitis, you will see something called draining sinus tract. And if you look at this bottom picture over here, you see this arrow. I don't know if it's clear, but try to look at it. You'll see the arrow pointing at a little like dot. It's a hole. So this is the draining sinus tract. And basically, it's like a tunnel between the bone and the skin, the outer part of the skin. So this tunnel is forming from the bone all the way out, and it's going to drain all of the pus and all of the fluid out of the infection inside. And this is a sign of chronic osteomyelitis, not acute, because in order to form the tunnel and get all that, you have to have it for a long time. And this acute is the more classic one that you think of in IV drug users, trauma, while chronic, you would think of someone who is diabetic and they have an ulcer that is complicated by osteomyelitis and they don't know because they can't feel it, especially if they're not inspecting their feet. So they wouldn't know and it stays for a long time and becomes a chronic infection. And if you see this upper picture over here, this is called a bone probe test. And basically you get a sterile probe, this like stick, and you put it into this ulcer. And this is a diabetic patient with a diabetic foot and a diabetic ulcer. You get the bone probe and you put it inside the ulcer, and if you push all the way inside, you're gonna feel the bone. You're gonna feel something hard, and this is gonna be the bone. And it means that this ulcer spread all the way to the bone, leading to osteomyelitis. Okay? One more thing for chronic osteomyelitis specifically, you're gonna have sequestra and involucrum. Okay? Remember in the pathogenesis, we said we have inflammation and then bone necrosis and then new bone formation. And we said that the bone necrosis and new bone formation are only going to be seen in chronic osteomyelitis. You don't have them in acute, they haven't been formed. Okay? So in acute osteomyelitis, you wouldn't see the sequestra, but in chronic, you would see sequestra and involucrum. And for diagnosis, again, we have some non-specific things like CBC, ESR, CRP, but they don't really tell you what exactly is there. They just tell you there's inflammation. You can also do some imaging, but importantly, you need to do a blood culture because, again, hematologenous spread can be the cause, and it's a very important cause. So blood culture, as well as this point number 3. And remember, before we do 2 or 3, you do those before you give antibiotics. Okay, so you take the blood culture, you take the biopsy, whatever, and then you give antibiotics. Now, what is this point number 3 in red? The way you're going to diagnose it is going to differ by whether it's an acute osteomyelitis or a chronic one. In acute, you have to take a bone biopsy, while in chronic, you can take an aspirate from the subperiosteal abscess. Remember subperiosteal abscess when the new bone formed and you had the bone, okay, and you had this little like bone forming on the side, and you had pus being trapped inside this new bone that's forming. This is the subperiosteal abscess, and you take an aspirate from this subperiosteal abscess, and specifically in a chronic case. Why can't you take an aspirate in an acute osteomyelitis? Since you just take an aspirate, why do you need a bone biopsy? Because you don't even have this subperiosteal abscess in acute, okay? It hasn't formed yet. You need to form new bone to have the abscess, okay? So in acute, you have to do a bone biopsy because that's your only option. And for chronic, you take aspirate from the subperiosteal abscess and you culture it. Now I'll just go quickly over some organisms that you took in your PhD lectures. I won't really go into details. I'll just point out some important features. So what is this organism? This is Staph aureus, And an important valence factor that you have to know is teichoic acid and lipoteichoic acid. Okay, remember how we said at the beginning that in septic arthritis, in osteomyelitis, you have the bacteria coming in, okay, it went inside. Now we need it to stick, okay? How does it stick? How does it adhere? By the teichoic acid. Teichoic acid is for adherence of Staph aureus to the surface, okay? And then its other valence factor is lipoteichoic acid. And lipoteichoic acid is what induces the cytokines. Okay, so teichoic acid for the adherence, and then lipoteichoic acid for inducing cytokines. Okay, next organism. And this one is also oxidase positive. This is Neisseria gonorrhea. You see this intracellular diplococci that are gram-negative. Um, so the important feature that you should know in Neisseria gonorrhea, especially when it comes to septic arthritis, is the phase variation or the antigenic variation. The fact that they have their antigens and they can change these antigens around, sort of like wear different costumes every time. So the immune system has a very hard time getting rid of the infection because it keeps changing its antigen. Every time it forms an antibody, the antigen changes. Okay. And for some reason, I saw a few questions about this. I remember a couple questions about this point. I would remember it if I was you. Phase variation or antigenic variation for Neisseria gonorrhea, especially in septic arthritis. And the last organism that we're going to talk about in this section is Echinella corridans. And we said that this is implicated in which infection, which osteomyelitis? In someone who's a fist fighter, because we said that it's part of the oral cavity microbiota. This is a microaerophilic gram-negative rod. Microaerophilic means that it needs very little oxygen to survive, and it's basically found in the oral cavity microbiota, and that's why it's important when it comes to human bite infections as well as fist injuries, fist fighters, because when someone bites someone, the bite can get infected by this because it's found in their oral cavity. And with this, we are done with the musculoskeletal part. Now we will go into the dermatology part. Just a second. Okay. So for dermatology, we're going to cover the bacterial, the viral, the fungal, and the parasitic. And before we do all that, let's go over the basic structure of the skin, which you guys should already know. This is skin. Down here, we have the subcutaneous fat, and then this is the dermis. Up here is the epidermis, and the uppermost layer of the epidermis is the stratum corneum, okay, made of all the dead keratinocytes. Here we have a hair shaft inside the hair follicle. Okay, hair follicle is the home of the hair shaft. And over here we have sebaceous glands, okay, just right beside the hair follicle. Okay, so again, subcutaneous fat, dermis, epidermis, stratum corneum, the hair follicle with the hair shaft, and sebaceous glands. Okay. Now, in dermatology infections, the level that's affected by each infection is an important thing because some infections are superficial, some are deep. So you should know that if you have an infection in the hair follicle, we call this folliculitis, which is perfect. It's easy for us to remember. Folliculitis, hair follicle. And then, if we're talking about superficial infections, we have impetigo and ecthyma. These are more superficial, especially impetigo is even more superficial than ecthyma. And then going into the dermis, we can have erysipelas, cellulitis affecting the dermis. So in epidermis, impetigo, ecthyma. In dermis, erysipelas, cellulitis. Then deeper than that, in the fascia and the muscle, you can have necrotizing fasciitis. Okay? This is the same thing we just said. The hair follicle folliculitis, epidermis, impetigo. In the dermis, we have erysipelas and cellulitis. Erysipelas is more superficial than cellulitis. Cellulitis can go even deeper. Okay, now we will start with the bacterial infections. And we divide the bacterial skin infections into two main categories, pyogenic versus toxin-mediated. The word pyogenic, when you see pyogenic, it's pus. Okay, it's purulent infection. So you have pus. And in order to have pus, you need the bacteria to be there and to be metabolizing and destroying the tissue around it. Okay? Because pus is basically all the cell debris from the dead cells and the dead neutrophils. So you need the bacteria to be there causing all the damage. Okay? So this is a pyogenic infection. It has pus inside, and again, bacteria is present there, and it's causing metabolism and tissue destruction. This is in contrast to toxin-mediated infections, because here the bacteria is not specifically, it's not necessarily in the lesion, the skin lesion. The bacteria is not necessarily there. The bacteria is just floating around the body, and it's making the toxin, and the toxin is gonna go and cause this skin manifestation, but the bacteria itself is not necessarily there. It's somewhere else and it's releasing the toxin, and the toxin is doing all the damage at the site. So in pyogenic, the bacteria itself is causing the damage. In toxin mediated, the toxin, the extracellular toxin being produced from somewhere different, is coming here and it's causing the damage. Now, for the dermatology part, it's going to be mostly spot diagnosis. So I'll show you a picture, and I want you guys to just identify what the infection is, because a lot of these infections in dermatology are spot diagnosis. They're clinical diagnosis, the very classic picture, and you need to know what it looks like. It's very important for you to know the pictures for your OSPE and for your MCQ in general anyway. So what is the diagnosis here? This is folliculitis. You see, you have these red dots and you have pus on the dots. And here as well, you have the pus and the red dots. Now, folliculitis is a pyogenic infection, just like we just saw pus, okay? And superficial, because folliculitis, it's in the hair follicle, so it's pretty superficial. And again, it's inflammation of the hair follicle. It's mostly caused by Staph aureus and MRSA. You're gonna see Staph aureus a lot during this lecture, and just remember, Staph aureus, Staph aureus, Staph aureus. I'll point out the specific exceptions to you so that you know which ones are not Staph aureus or which ones have other organisms involved. But if you're stuck in general and it's not one of the exceptions that you know, just pick Staph aureus, and there's a very good chance that you will be correct. Okay? Now, folliculitis, if it affects the beard, it has a specific name, which is Psychosis barbae. This still is folliculitis, but when it affects the beard, we call it this special name. And barbae is beard, so the word barbae refers to the beard. And this is not the same as razor bumps. When someone shaves and they get razor bumps, just the red dots, those are because of ingrown hair. But here, we actually have pus. In the razor bumps, there's no pus. In folliculitis, you have pus, okay? So this still is folliculitis, it's just in the beard and it has a specific name because of that. Another type of folliculitis is hot tub folliculitis. This is due to Pseudomonas aeruginosa infection. And Pseudomonas aeruginosa is a gram-negative bacteria. And if you watch the sketch sheet for it, you would remember the hot tub, because hot tub folliculitis. So again, folliculitis in general is mostly due to Staph aureus or MRSA, which is also Staph aureus. But in a specific patient, like if the patient comes with folliculitis and they tell you that they were using a lot of hot tubs or swimming pools, then you need to suspect Pseudomonas as well in your differential, okay? So folliculitis equals Staph aureus MRSA. If the patient has a history of hot tubs or swimming pools, you want to consider Pseudomonas for hot tub folliculitis. Next one. This is a furuncle or a skin abscess. The skin abscess is basically a deeper form of folliculitis. So you have folliculitis, and then if it goes even deeper down into the base of the hair follicle, it could cause a furuncle or a skin abscess. So it's a single follicle that gets infected, and the infection goes deep into the dermis. Okay, so it's also pyogenic because, as you see, there's pus inside, and because it's essentially an extension of folliculitis. And because of that, because it's closely related to folliculitis, it's caused by the same bacteria, Staph aureus / MRSA. And since it's an abscess, you know, if you know the main the pathology behind skin abscess or any abscess in general, is you have infection, and this infection is destroying tissue. So there is tissue destruction and necrosis, forming this cavity, this empty cavity, because of the necrosis, and then this cavity gets filled with pus. Okay, so this pus-filled cavity is the abscess. So here you have tissue destruction causing necrosis, and because of the tissue destruction and there's a lot of inflammation, you see how red it is, you're gonna have a lot of constitutional symptoms and you're gonna have pain. It's gonna be pretty painful because it looks very inflamed, and you're gonna have constitutional symptoms like fever and lymphadenopathy. Now, so this looks like an abscess. If you imagine an abscess, this is what it looks like. It's also called a boil, okay? But the name is a furuncle. And if you, again, the Staph aureus sketchy, remember this camel has these camel humps that are red for abscess. So it causes abscesses in general, one of which is a skin abscess or a furuncle. Okay, next. Okay, this is a carbuncle. The carbuncle is basically a bunch of furuncles beside each other that formed a carbuncle. Okay, so furuncle, furuncle, furuncle coalesced together and they formed one big abscess called a carbuncle. And you look how inflamed it is, and there's so much pus inside. There's a lot of pus, so it's pyogenic. And as we said, it's multiple furuncles coming together to form one huge abscess. And it's very inflamed. It's usually found in the nape of the neck or the upper shoulder and like the upper chest, I mean upper back and shoulders, this area, just like the pictures. And again, the organism, Staph aureus, MRSA, because it's closely related to the previous two, but you do have some other organisms as well, beta hemolytic strep and gram-negative bacteria. But it's just remember Staph aureus. It's very important for you to remember Staph aureus. So far, we said folliculitis, furuncle, and carbuncles are all associated with Staph aureus. Okay? All right, next diagnosis. Okay, this is impetigo, and you see the honey-colored, crusty appearance. What is this? This is bullous impetigo. It's a special type of impetigo. We're gonna discuss it more in a second. And this one. This is ecthyma. So you see the punched out lesion, it's ecthyma. And these two have different etiologies. We're gonna go into details in a couple slides. So just know that this round punched out lesion is ecthyma. Okay, now impetigo. Impetigo is more commonly seen in children and it's pretty contagious. It's superficial in the epidermis, as we said. If you remember this picture, the epidermis here, you see there's impetigo. So it's a superficial infection. It affects mostly children, and we can have primary versus secondary. When we say primary impetigo, it's just a child who's completely healthy, and they just so happen to get impetigo on their face, okay? But secondary impetigo is in someone who has a skin disorder that makes chronic skin breaches. There's breaks in the skin. Like if a kid has eczema and the eczema is, the skin barrier is lost, okay? They have inflammation on their skin, they have breaks in the skin. So because of the breaks and because the skin barrier is damaged, they're more likely to get infections, including impetigo. So if you see impetigo in a kid who has eczema and the impetigo is superimposed on the eczema, in that case we call it secondary impetigo. And we have three types: non-bullous, which is the classic impetigo, the honey-colored crust. There's bullous impetigo and there's ecthyma. But we're gonna go more into these details in a second. Before we do that, let's just briefly say the diagnosis and treatment. For diagnosis, it's mainly a clinical diagnosis because the way the rash looks is pretty obvious. So clinical diagnosis, and the you can also do a culture of the bullous fluid or pus. Okay. And for treatment, you give antibiotics. And it's important to remember the antibiotics because if you remember in strep pyogenes, as we will see in a second, it can cause glomerulonephritis as a complication. So you need to give antibiotics in order to avoid complications of strep pyogenes. Now let's discuss the classic impetigo. So as we said, there are three types. This is the first one, the non-bullous impetigo, which is the classic one. And it's caused by Staph aureus and strep pyogenes. Again, Staph aureus is still there, but a new or bacteria popped in, it's strep pyogenes. And I would really remember this. I would remember both, actually. Strep pyogenes is group A beta hemolytic strep. Now, how does this impetigo form? First, you get papules, and then the papules will break. Um, Hold on, no. You get papules, and then the papules will turn into vesicles, and then these vesicles will break. They're gonna just pop, and when they do, they release the pus that's inside the vesicle, and when the pus is released, it's gonna form this crust, this thick golden colored crust. Okay, it's what gives the honey colored appearance. This one. So papule, and then it becomes a vesicle, and then the vesicle will break and give you the crust. This is also, you see a lot of crust and there's erythema. This is a very classic rash, and remember the picture, okay? And if you watched Strep Sketchy again, you would remember this guy in the back. It's not very clear here if you want to zoom in, but he has some honey-colored crust on his face, okay, just like this picture, right? Strep pyogenes. So Staph aureus and Strep pyogenes in the non-bullous classic impetigo. This is unlike the bullous impetigo. We said this one is non-bullous. Here is bullous. Bullous impetigo is only due to Staph aureus. You don't have strep pyogenes here. Why is that? Because if you study the bullous disorders, you would know that the bulla form when you have destruction of the epidermis. So you have the epidermis and you have desmosomes connecting the keratinocytes in the epidermis. If you have something that destroys these desmosomes and have them separate, you're gonna form the bulla. Okay? So in order to form bulla, to get bullous impetigo, you need to have this specific toxin, which is the exfoliative toxin. And exfoliative toxin is gonna go attached to the desmosomes, destroy them, and lead to the formation of bulla. This exfoliative toxin is one of the virulence factors of Staph aureus, okay? That's why bullous impetigo, which has exfoliative toxins, is due to Staph aureus. There's no strep pyogenes here, it's Staph aureus. This toxin is the same one that we're going to see in the staph scalded skin syndrome in a second, so just remember it. Exfoliative exfoliation is when you like have sloughing off of the skin. So yeah. So bullous impetigo, staph aureus, exfoliative toxin. And remember the picture of the bulla. Okay. Now the third type of impetigo, we said we have the classic non-bullous, and then we have the bullous, and finally we have ecthyma. Now, ecthyma is not necessarily due to impetigo only. We can have two presentations of ecthyma, this one, and they're not the same, okay? This one on the left, you see you have this punched out lesion. It's like a very clear circle, and there is erythema inside, and there's erythema outside, and the border is like rolled up and red, okay? This ecthyma, which is very red, is ulcerative impetigo. It's one of the stages of impetigo. So when the impetigo that we saw previously becomes ulcerated, when it forms an ulcer, it can be called ecthyma, okay? When it gives this look, okay? So ecthyma, ulcerative impetigo, is a stage of impetigo. And again, the organisms are Staph aureus, strep pyogenes, because same thing as impetigo. It's a stage of impetigo. This is not the same as ecthyma gangrenosum. These two are different. This ecthyma on the left that looks red is ulcerative impetigo. It's one of the stages of impetigo. The one on the right, ecthyma gangrenosum, is completely different diagnosis, completely different bacteria, completely different, okay? And it looks different too. If you look, this one that we talked about is red, but this one is black, okay? The sponged out lesion, it has black in the center. Black equals necrosis, that tissue, okay? So from the name, gangrenosum, because you know the gangrene is dead tissue. So ecthyma gangrenosum is due to necrosis. And so you have black appearance inside the punched out lesion. And this is due to a disseminated Pseudomonas infection, and especially in an immunocompromised patient, okay? So if you see this picture on the left, the red lesion, this is ulcerative impetigo, one of the stages of impetigo, and it's due to these organisms, while the one on the right, which has black in it, is ecthyma gangrenosum because of the black necrosis, gangrenosum, and it's due to Pseudomonas in an immunocompromised patient. Has nothing to do with impetigo, okay? It's a completely different entity. And remember Pseudomonas for this one. It's an important association, and they could ask about it. I remember having a question about this. So ecthyma gangrenosum with the black is due to Pseudomonas in an immunocompromised patient. Now, the next diagnosis. This is erysipelas. Okay, next one. This is cellulitis. So, how do you tell the difference? First of all, what's common between them? They are both infection and inflammation in the dermis. Okay, they both lead to erythema, swelling, pain with or without fever. They both do not have pus, there's no purulent discharge, and they're both treated with antibiotics because they are bacterial infection. Okay? So erythema, swelling, pain, and yeah. Now, how do you tell the difference between them? Okay? Erysipelas is more superficial. It's in the upper dermis, while cellulitis is in the lower dermis. Okay? Erysipelas is well demarcated and it's slightly raised, while cellulitis is not well demarcated. It has a very faint border. Okay, and we'll go back to the pictures for you to be able to tell. If you look at erysipelas over here, you can tell that it has a very clear margin. It's a very clear border. Okay, and you can clearly tell the difference between the normal skin and the infected skin. Look how red this is in comparison to this part. Okay, so it has a erysipelas has a very clear border, and it's also a raised lesion. I don't know if you can tell in this picture, because of the angle and everything, but take my word for it, this is a raised lesion. So in erysipelas, it's a well demarcated raised lesion in the upper dermis. Okay, remember the well demarcation. If you see well demarcated erysipelas, all right? Versus cellulitis, which is not well demarcated, it's just redness. And if you look here, you can kind of tell that there's a difference, but still the line is not as obvious as this one. Like, look how sharp the line is. This is healthy, this is red. Like, it's very clear. But here, it's more like kind of like a gradual redness. Um, so it's not as obvious as the other one. And it's not as raised as the other one. It's kind of swelling because of the inflammation, but it's not a raised lesion. Okay, it's more like the whole skin is a bit swollen. There's no like specific raised lesion. Okay, so back to this. Erysipelas in the upper dermis, it's well demarcated and raised, while cellulitis is in the deeper dermis. It's not as well demarcated and is not as raised as erysipelas. Which bacteria causes them? Both of them are caused by strep pyogenes. Okay, strep pyogenes is in both. Erysipelas is only caused by strep pyogenes, while cellulitis is caused by strep pyogenes as well as other bacteria. So, what other bacteria? We have strep egalactia or group B strep, specifically in newborns. Again, whenever you see this, just think newborns. No one really other than newborns will get this infection. We also have Staph aureus and MRSA. Of course, we have it. It won't be an infection in the skin without having Staph aureus. But again, be careful. Erysipelas does not have Staph aureus. Okay, erysipelas is only due to strep pyogenes. These other ones are only in cellulitis. Okay, we can also have Haemophilus influenza type B, specifically in buccal cellulitis in children. So buccal cellulitis is in the cheek, and this one is pretty dangerous actually. If they get this, you need to treat them like very quickly because it's dangerous. Then we have these other two, which are Eromonas hydrophilia and Vibrio vulnificus, and they're both associated with water infections. And it's usually when someone has a trauma when they're inside the water and they, trauma to their leg, for example, and then they end up getting cellulitis and can be due to one of these two. If it's fresh water, then it's Eromonas hydrophilia, and if it's salty, think of Vibrio vulnificus. Okay? And I don't know why when I think of Vibrio vulnificus, I think of what's it called? Seashells. I don't know why, but I just think of Vibrio vulnificus, I imagine seashells, and sea is salty water, okay? Versus Aeromonas, fresh water. This is a very stupid association. I don't know how I came up with it, but it's in my brain, so maybe it helps you. But yeah, so just know that strep pyogenes is in both. Erysipelas only has strep pyogenes. Cellulitis can have strep pyogenes plus any of these other ones. And this is again sketchy for strep pyogenes, and you would remember the red gloves. This is for both erysipelas and cellulitis, okay? They can both be caused by this. But again, erysipelas, only strep pyogenes. No Staph aureus in erysipelas, only strep pyogenes. Okay, and just to recap everything we talked about, same picture that we keep showing every now and then. In the epidermis, there's impetigo, and then erysipelas is in the dermis. Cellulitis is also in the dermis, but it goes even deeper sometimes. So erysipelas is a superficial dermis, cellulitis is deep dermis, and there's folliculitis in the hair follicle. Now for this diagnosis, this is Staph scalded skin syndrome. The word scald is a burn from very hot liquid. Like if someone drops a pot of very like boiling water on them and they get a burn, it will be a scalding burn. And it usually looks something like this. Okay, that's where they got the name, scalded skin. And staphylococcal, obviously, because it's caused by staph. Okay, so it's Staph aureus from the name staphylococcal, Staph aureus. This is toxin mediated. And remember how in the bullous impetigo we talked about the exfoliative toxin by Staph aureus, and it's what gives you the bulla. The same toxin, the exfoliative toxin, is also seen in Staph scalded skin syndrome, and it's what causes the sloughing off. So again, exfoliative toxin destroys the desmosomes by targeting desmoglein 1, which is part of desmosomes. So when it targets the desmosomes, it's gonna damage the epidermis, the keratinocytes separate, and you can have bulla and desquamation. They can just rupture and the skin will slough off, okay? And again, Staph scalded skin syndrome is caused by Staph aureus due to the exfoliative toxin. And this is a toxin-mediated infection or syndrome. Okay, Staph aureus is just somewhere in the body, like not necessarily on the skin. It's just floating around, forming the toxin, and the toxin is damaging the skin. And this is mostly seen in children, renal failure, immunocompromised patients. And you should also know this point that Staph scalded skin syndrome does not affect the mucous membranes. And by mucous membranes, I mean the oral cavity. Okay, this is to differentiate it from another similar entity that's called Stevens-Johnson syndrome, which also causes the sloughing off of the skin and desquamation. It causes a very similar picture to this, but the key difference is that in Staph scalded skin syndrome, the mouth is not affected, okay? But in Stevens-Johnson syndrome, the mouth will be affected, okay? And yeah, back to the same Staph aureus picture. Remember this guy down here? Look at his head. It's red because of the scalding of the skin. Okay? And just like I want you to connect them. If you watch Sketchy in POD, it's really nice to connect the micro in these coming blocks with the POD Sketchy that you did. It just makes the picture stick. Okay? So Staph scalded skin syndrome due to Staph aureus from the name and exfoliative toxin. That's what causes the desquamation. Now, diagnosis. This is acne vulgaris, and we're going to talk about the differences between all these pictures in a second. So, what is acne vulgaris? It's a chronic inflammation of the pilosebaceous unit. Remember this picture that we talked about at the beginning? We have the hair follicle and the hair shaft, and we have the sebaceous gland right beside the hair follicle. And if you have chronic inflammation of this pilosebaceous unit with the sebaceous gland and everything, you get acne vulgaris. And we have three key parts of the pathogenesis of this infection. It's due to 1, keratinization, 2, sebum production, and 3, inflammation by the Cutibacterium acnes bacteria. Okay? So hyperkeratinization is basically when you have a lot of keratin forming, and a lot of keratin being formed is gonna cause a keratin plug that's gonna clog the pore. Okay? So you have clogging of the pore by a lot of keratin, hyperkeratinization. And you also have a lot of sebum production, and the sebum production is mainly due to androgen, okay? And that's why acne vulgaris, you see it more in adolescents because there's a lot of androgen being released, and so the androgen is going to cause more sebum production, leading to acne, okay? So we said there's a lot of sebum and there's a lot of keratin, okay? That's clogging the spore. The third is inflammation by Cutibacterium acnes. And Cutibacterium acnes is one of the microbiota of the skin. So it is normally found on your skin, but it's just chilling there normally. Now, in someone who has the hyperkeratinization, the clogging of the pore, and a lot of sebum, the Cutibacterium acnes, instead of just being chilling in the pore that's open, now the pore is clogged, and the Cutibacterium is trapped inside the clogged pore, and there's a lot of sebum in the pore as well. And sebum is oil, okay? If someone, sebum production, the skin is feels oily because sebum is oil. It has glycerol and oil inside. So the Cutibacterium acnes, which is trapped inside the pore, is gonna have a party with the sebum. It's gonna digest the sebum. It's gonna create fatty acids, and the fatty acids that are produced are gonna induce all of the inflammation. Okay, so it starts with the hyperkeratinization and the increased sebum production, which trap the bacteria inside, leading to inflammation. The bacteria is what causes the inflammation. Okay. So with that, we have three different presentations of acne vulgaris. We have comedonal acne, inflammatory, and nodular cystic. The three are different stages of the same disease, okay? They're not like different they don't present separately. They usually present together. You would see all three of them, or you would just see the more like the milder case, like a comedone. Nodular cystic is basically the most severe form of all of these. Okay, so the whole thing starts at the comedone, and as we said in the last slide, the whole story starts by clogging the pore, okay, due to hyperkeratinization and sebum. And when you clog the pore, you're gonna form the comedone. The comedone is basically this raised bump, okay, that has pus inside and all of the clogged sebum inside. Now, we can have open comedones and closed comedones, and the difference is that the closed comedone looks white versus the open comedone, which looks black. Okay, the why is the open comedone black? Because when it's open and all the sebum that's inside is exposed to the air and exposed to oxygen in the air, it's gonna get oxidized and it will turn black. Okay, so comedones can either be white, which are closed, or they can be open, which are black comedones. Okay. And this is what comedones look like. You see the black dots here. These are all open comedones. And the defining feature of acne vulgaris is the comedones. If you don't see comedones, this is not acne. Comedones equals acne, okay? It starts here. Now, as we said, we clogged the pore, we trapped the bacteria, Cutibacterium acnes, and bacteria induces a lot of inflammation. When it does that, you get inflammatory acne. So you have the same comedones, okay, but now they are inflamed. You see how red they are. You also do see some inflammation here, by the way. Look, that's why I told you like they present together. Okay? So comedones form first from the plugging of the core, from the clogging of the pore, and then when the inflammation happens, you get inflammatory acne. Now, if it gets even more severe and the inflammation gets so severe, you will have nodular cystic acne, which is the same thing but a more severe form. So you see these nodules over here forming and cysts. So in this picture, you can actually see all the stages. You can see some closed comedones here, and you see also some open comedones like this one and these ones. Okay, you see some inflammatory acne like these redness here, this. There's also some over here. And you see these big nodules. These big nodules are what tell you that this is a nodular cystic acne. Again, these are all the same condition, just at different stages. And acne vulgaris equals comedones. Okay? Now, what is this organism? This is Cutibacterium acnes. And for some reason, they love this picture. I don't know why, they just love it. So I don't know what you're supposed to see. Cutibacterium is a gram-positive rod, okay? It looks like any gram-positive rod, but just memorize this picture. They always bring it. They always ask about this exact same specific picture. So just know this picture is for Cutibacterium acnes, okay? Which is for acne vulgaris. Now more about Cutibacterium acnes. It's part of the skin microbiota, as we said. It is microaerophilic, meaning it needs very little oxygen, and that's why when the pore is clogged and this bacteria is inside, doesn't have a lot of oxygen, it's fine. Like it can still live because it doesn't even need that much oxygen. And again, it's a non-spore forming gram-positive rod. It's pleomorphic, so it forms a lot of shapes, as you see here. Some of them are long, some of them are short. And as we said, it will digest all of the sebum, releasing fatty acids, and the fatty acids released by this bacteria are what cause the inflammation. Okay, next, this organism. I think we already saw the same exact picture, but yeah. This is Staph aureus. And we talked about the teichoic and lipoteichoic acid in Staph aureus and osteomyelitis. Here, an important virulence factor to remember is the exfoliative toxin that we saw in both the staph scalded skin syndrome as well as the bullous impetigo. And this exfoliative toxin due to Staph aureus is what causes the skin to peel and form the bulla. Okay, next organism, camp test. This is Strep egalactia. These are all, you should know all these from PODE, and I don't think you should really go into the details. Just know the virulence factors that I'm pointing out that have specific correlations with diseases that we saw, okay? But just know the pictures as well for completion's sake. And I added more information about each bacteria in the notes section of the slides if you want to take a look over it. Next one. And this one is bacitracin sensitive. So this is strep pyogenes. And the last one, this is green and it's gram-negative rods, so it's Pseudomonas aeruginosa, okay? And with that, we're done with the bacterial infections. We actually finished the majority of this, so we're done with 2/3. The coming part is, a lot simpler, inshallah. We finished the big bulk of the micro. So our next section is viral infections. Again, we'll use the same format. So what is the diagnosis here? What's the organism implicated? This is herpes simplex virus. Now, what is this picture? What's the organism or not organism? What is this most likely seen in? Okay. This one is it's also seen in herpes simplex. Now, these are Zank cells. We're gonna refer back to this picture in a second. But these are Zank cells on a Zank smear, which is seen in herpes simplex as well. And I'll dive more into this in a second, okay? So, herpes simplex virus. This vesicular rash is very classic for herpes simplex. It has a classic description, which is dewdrops on a rose petal. Rose petal is because of the erythema that's underlying it. And then the dewdrops are the actual vesicular rash. So it's a vesicular rash on an erythematous base. And you see here it's over the mouth. This is orolabial herpes. And here it's on the hand. Now, for herpes simplex, I'll just quickly talk about some basic virology that you should probably know from POD, but honestly, if you don't, it's okay. I'm not judging because I don't know it before then either. But in viruses, we have a big family of viruses called herpes viruses. Okay, these herpes viruses have a lot of viruses under them. One of those members of this family is herpes simplex. Okay, so those are herpes viruses. One of the herpes viruses is herpes simplex. Another one of this herpes family is varicella zoster virus. So herpes simplex virus is a member of the herpes viruses family. Okay? Other members of the same family are varicella, as we said, CMV, EBV. So they're all part of the same family, and they all have shared characteristics, which is that they are double-stranded DNA viruses, as well as that they exhibit latency. Latency means that you get the initial infection, the primary infection, and then the virus will go into the ganglia. It's going to go into the neurons and then go into the sensory ganglia, and the virus will hide there okay, after the primary infection has resolved, okay, the virus will be hiding in the ganglia and in the neurons, and then when the person is stressed or gets immunocompromised, they're gonna get reactivation of this viral infection. And this latency is a feature in all of the herpes family, okay? One of those is herpes simplex. So what happens is this infection is transmitted, first of all, okay, we have two types of herpes simplex viruses, HSV1 and HSV2, okay? They are the same virus, just two different strains. HSV1 is the one that you see around the mouth, and HSV2 is sexually transmitted, okay? So just remember that HSV1 affects above the diaphragm, while HSV2 affects below the diaphragm, okay? Because 2 is an STI and 1 is around the mouth, okay? So when they acquire this infection by direct contact, because this vesicular rash is actually very infectious, okay? So they acquire it by direct contact with a lesion on someone else, and this is the site of entry, okay? So in the primary infection, when the person first gets it, the virus will enter at this place, the place where it entered, you get the vesicular rash, and then it's gonna go hide in the neurons. The initial primary rash that they got will go away, and the virus will be hiding in the neurons, and the person will be completely fine. Now, if the person gets immunocompromised later on, they get the same rash at the same site of entry, okay? And every time they get reactivation, they will get the rash at the same place, okay? Now the next virus is okay, so this is varicella zoster virus or chickenpox. Okay, now this specific one is chickenpox. Okay, remember how we said we have the herpes family, and one of the members of this family is herpes simplex. Another member of the same family is varicella zoster virus. All right, and since it's part of the same family, it's gonna have the same feature of latency. Okay, so if this is the primary infection, which is chickenpox, what is this? This is a secondary infection of varicella zoster virus, which is shingles. Now let's just step back into this, okay? So we finished talking about herpes simplex. Now we'll talk about varicella zoster virus. For varicella zoster, the primary infection is chickenpox. So this child, okay, this is his or her, I don't know, first exposure to this virus, varicella. And this first exposure, the primary infection, we call it chickenpox. And it causes this vesicular rash all throughout the body. Again, it's a vesicle on an erythematous base, and the rash is at different stages of development. So you will see a blister, and it starts with the papule, this tiny papule, and then it will form a blister or a vesicle. Okay, and then the vesicle will ulcerate, you get an ulcer, and then the ulcerated vesicle is gonna rupture, and you're gonna get scabbing. So these are all different stages of the same lesion. Okay, so it's very classic that in chickenpox you see the vesicular rash at different stages of development. If you see this description, this is very characteristic of chickenpox. And again, this is varicella zoster. Varicella zoster virus is acquired by inhalation. So it's through droplets. It's not like simplex, which was by contact. The varicella zoster is due to inhalation of the viral particles. So primary infection of varicella is chickenpox, and the secondary infection is shingles. And again, because it's part of the same family as herpes simplex, it's gonna have the same latency that it had. So this child who got chickenpox when they're a kid, once the chickenpox is treated and they're fine, they don't have any more rash, the virus is still hiding in their dorsal root ganglia. And when this child grows up, okay, they could get this if they become immunocompromised or become stressed at some point, okay? So this shingles is a vesicular rash in a dermatomal distribution. It's very classic for shingles, which is the secondary infection, secondary presentation of varicella. This, look how it's a very like a belt, okay? It's a vesicular rash in a dermatomal distribution. This is shingles. And because it affects the nerves and the virus is in the nerves, there's a very classic presentation which is post-herpetic neuralgia. This shingles is actually very painful and it has a very sharp burning sensation. Okay, so just to summarize, varicella zoster, primary infection in a child is, or in an adult, but most commonly in a child, is chickenpox. And then there's latency. There's a period where nothing is happening. The virus is just hiding in the nerves. And then at some point later on, if this child, when they grow up, they become immunocompromised, they can get shingles, okay? Which is the reactivation of varicella. Now, back to the same picture, which we said we see in herpes simplex and varicella, okay? Because they are both, as we said, they're both part of the same family, the herpes viruses family. So in both, you would see this classic picture, which is at multinucleated giant cells on Zank smear. So you take scrapings of the vesicles and then you put them under the microscope, and you would see these multinucleated giant cells under the microscope, and this smear is called a Zank smear. This is not specific for either one of these. You could see it in both. It's classically associated with herpes simplex, but it is seen in both, okay? And this is not really done clinically, usually, because if you want to scrape off the vesicle is very painful. If you're gonna try to scrape off the vesicle, it's just unnecessary pain. But it's a classic presentation that they like to put in questions, in exam questions. So look out for Zank smear for herpes simplex virus or varicella zoster, especially in herpes simplex, okay? Where you see the multinucleated giant cells on Zank smear. Now, when you want to diagnose these, what we actually do clinically is, first of all, there's the clinical appearance of the rash. It's a very distinct rash, so the clinical diagnosis aspect is important. But we do have other methods. We can look for the viral antigen, or we can look for the viral DNA, okay? And these can get kind of confusing, so just know that if you're looking for the viral antigen, you're using immunofluorescence, because immuno, okay, means that you have antibodies involved, and these antibodies that you use in immunofluorescence are going to go and they are going to target the antigens. So if you're looking for antigens, you want to use antibodies, which are immunofluorescence. The other one, when you're looking for the viral DNA, it's through molecular assay, okay? Molecular assay looks for the genetic material of whatever you're looking for. In this case, it's viral DNA, so you use molecular assay to look for the viral DNA, and this is like PCR, okay? PCR is very commonly used for viral infections in general, and this molecular assay to look for the viral DNA is actually preferred over the viral antigen just because it's a lot easier, and this is in general what's used for viral infections in a lot of viral infections. So how do you diagnose herpes simplex virus and varicella zoster virus? Molecular assay to look for viral DNA, okay? And a classic description that you would see in exam questions is a Zank smear with multinucleated giant cells. Just this picture, all right? Know the pictures. You can also do culture and serology, but they're not done clinically. They're only done for research purposes. But just here for completion's sake, okay? Now our next presentation is this one. This is Kaposi sarcoma, human herpes virus 8, okay? Now, you see this very like purplish rash. It's very distinct for Kaposi sarcoma, and it's due to human herpes virus 8. This virus is also one of the viruses in the herpes virus family, okay? Just like the previous two. This one specifically targets B cells as their primary target. So they infect the B cells and they hide. And when someone gets AIDS, this virus can induce Kaposi sarcoma, okay? How do they do that? The virus is hiding in B cells, as we said. And it's gonna stay there, and then if someone gets AIDS, the virus is gonna be like energized. It's going to do two things. It's gonna promote growth and prevent apoptosis. And if you know anything about pathology, in cancer pathology, this is how cancer develops. You either have a lot of growth or you have no death, okay? So no apoptosis or a lot of growth. And the human herpes virus 8 is going to induce both. It's going to promote growth and prevent apoptosis, leading to cancer, which is Kaposi sarcoma. And this Kaposi sarcoma is an AIDS-defining illness. What that means is if you see someone with Kaposi sarcoma, the high chances are that they have AIDS, okay? It's an AIDS-defining illness. Now, how do you diagnose it? You need histopathology, okay? PCR and all that would not be enough. You need to actually take a pathology of the lesion because it is cancer, it is sarcoma after all. So you need to take a pathology sample, a biopsy, and this is actually the gold standard. Okay, so this is Kaposi sarcoma due to HHV8, and it is in an AIDS defining illness. Okay, next one. Okay, this is parvovirus B19. Another name for it is erythema infectiosum or fifth disease, and it classically has a slapped cheek appearance. Now, fifth disease is, I don't think you should really know this. I mean, you can if you want to, but it's not very commonly used anymore. But generally, in childhood, you have a lot of infections that can cause rashes, okay? There's measles, there's mumps, there's rubella, scarlet fever. All those things can cause rashes, and the rashes look pretty similar, but they have their distinct features. So they classified the childhood exanthems or rashes into different classifications based on number. So there's first disease, second disease, up until sixth disease, I think. The fifth disease is this one. Erythema infectiosum due to parvovirus B19. Do you need to know this? Not really. Okay, it's not important, but just keep in mind that it is the fifth disease. Okay, and it causes a very classic slapped cheek rash. You look at this child; they have a rash on their cheek as if they were slapped on their cheek. So slapped cheek equals parvovirus B19. And this is a DNA virus, and it's the smallest DNA virus. The target of the virus is erythroid precursor cells. Um, I don't know if you took this because you didn't take heme-onc, but I'll just explain it briefly. Um, in parvovirus B19, because it targets erythroid precursor cells, basically the cells that are making the RBCs, if a patient has chronic hemolytic anemia, and they get a parvovirus B19 infection and it targets their erythroid precursors, basically they can fall into something called aplastic crisis. Okay? You have an idea about it. I don't know if they will ask you because you didn't take heme-onc, but just have an idea. Parvovirus B19 in someone who has a chronic hemolytic anemia can get aplastic crisis. So they just have an acute aplastic anemia because of this. Okay? And another thing as well, that this virus, if it infects an adult, it can cause polyarthritis, okay? The most important thing that you should know here is that parvovirus B19 causes a slapped cheek appearance, slapped cheek rash, which is also called erythema infectiosum, and this is the classic picture, okay? It's the most important thing for you to know. Okay, next. This is molluscum contagiosum caused by a pox virus. It has a very characteristic look. So it's a rash with these nodules that are pearl-like and they have an umbilicated center. Okay, so look at the it's a nodule and it's very shiny. It looks like a pearl, and the center looks like it has a dimpling or like an umbilicus. Okay, it looks like a donut kind of, or like an RBC. So yeah, it's a pearl-like umbilicated nodule, and you should be able to recognize the picture as well as the description. Like if they give you a question and they tell you this child had a pearl-like umbilicated nodule, they didn't show you a picture, but they just described it with this exact same description. You should know that this is molluscum contagiosum. It's a very characteristic description of the rash, okay? And the rash may sometimes look like this, which does not have the classic appearance, so it can look wart-like or pedunculated, so it can be confused for warts. Um, it's most commonly seen on the trunk, in the genitalia, and proximal extremities. And when you diagnose it, if you take a pathology from this nodule, okay, or from this, you would see molluscan bodies on histopathology. What does that mean? This is a molluscan body, again, molluscum contagiosum, molluscan body on histopathology. This is the picture in your slides, but I found it a bit not clear, so I got another picture to show you. And I got this off of Google, but I remember seeing this somewhere. I don't know where, but I don't know, it struck something in my memory, so I put it for you guys. So you should probably know this picture. It looks like a flower, kind of, look like petals and stuff. And this is the lesion, basically. This is the nodule. And molluscan bodies are these eosinophilic circles, okay? Look here, it's pointing towards them, these red circles. They're more clear on this picture. If you look here, where I'm pointing, okay, we have these red circles all over. Like here, 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 they're all red circles. These red circles are the molluscan bodies, okay? So just know this like flower or garlic appearance, I don't know, and the molluscan bodies for molluscum contagiosum. And also know the description of the nodule, pearl-like umbilicated, as well as the picture. Okay, know the picture. Okay, next one. This is Mpox, which was previously known as monkeypox. Now, this one is also a double-stranded DNA virus of the genus Orthopox virus. And it was initially thought to be zoonotic. It was initially zoonotic, that's why it was called monkeypox, okay? But a few years ago, in 2022, there was a global outbreak, and at the time they thought it was an STI, okay? But then now they discovered that it can be, transmitted by anyone having direct contact with the rash. And this is what the rash looks like. It looks kind of like um, a nodule that also looks like a wart. I don't really know how to describe it. It looks like those like nodular balls, kind of. So just remember the pictures, just memorize the pictures. Um, but yeah, and we have something in these viruses by which they classify the Mpox viruses. They classify them into clades, okay, which are like classes of the viruses, like different strains, okay. We have clade 1, clade 2. The one that was responsible for the global outbreak a couple years ago is clade 2b strain. Is this important? Honestly, I don't think so, but I just put it here for completion's sake. The lesions tend to be perianal and perioral, like you see here around the mouth and also around the genital area, because it was sexually transmitted at some point, and it can be sexually transmitted. They get skin rash, mucosal lesions. They also get a fever, headache, muscle aches, back pain, low energy, swollen lymph nodes. And as we said, transmission is through close contact with the rash, either with another person, with an animal, remember, monkey. Okay, so if someone works in a zoo or close with monkeys, they can be at risk. Or also material. So if someone has this rash and they use a razor to shave their beard and then they don't clean the razor and then someone else uses the exact same razor, like in a barber shop, for example, they can get this. And it can be transmitted from a mother to her fetus, either in utero or during delivery. Okay? Um, yeah, and this is it for all the viral infections. Now we are gonna move into fungal infections. Um, and just some basic concepts of mycology that you probably know from POD. I'll just, say them briefly. You have cell walls in fungi, and the cell walls have polysaccharides, chitin, glucans, mannans, and you also have membrane, which is made of ergosterol. Fungi are aerobic, and they have two phases of growth, vegetative phase and the reproductive phase. Vegetative is just mitosis, it's just the cell dividing to like grow longer, okay, for the hyphae to grow. But reproductive is when you have sexual or asexual reproduction, asexual by spores. All right. So yeah, another thing for fungi, they can have hyphae, which are these long, hyphae, and they can have septa, and you can have also unicellular yeast cells. Some of them change back and forth between the hyphae and the yeast. We call them dimorphic. These are basic concepts of mycology. And the more important part is the fungal skin infections, okay? When it comes to the skin specifically, we can have superficial mycoses and we can have cutaneous mycoses. For superficial, they are the ones that colonize the outer layer of the skin. So they colonize the stratum corneum, the hair, the nails, basically keratin. Okay, they love keratin and they're very superficial. We have different types. We have pityriasis, tinea versicolor, and we have all these other ones. The one you should focus on is pityriasis, tinea versicolor, due to Malassezia furfur. We're gonna dive deeper into it. The other ones, tinea nigra, white piedra, black piedra, not really important for you to know. Just know that they affect the hair. They can affect hair, on the scalp. Just know that. But the one you should focus on is pityriasis versicolor. Now, this is superficial mycoses. We also have cutaneous mycoses, which are due to dermatophytes. Okay? Now, we divide the dermatophytes into three categories. These are the three different fungi that fall under the same group of dermatophytes, which are epidermophyton, trichophyton, and microsporum. So, this is the general classification. Now we'll go more into the details of these. Starting with the first one, what is the diagnosis? This is tinea versicolor caused by Malassezia. So what is tinea versicolor? It's a superficial mycosis, as we said here, it's part of this group, okay? And it affects the keratinized structures, and it causes these lesions that can either be hypopigmented or hyperpigmented. On someone who is dark-skinned or more tan, the lesions will look hypopigmented, like this over here. On someone who has a more fair skin, the lesion is going to look hyperpigmented, like here or here, okay? So look, this is the lesion. And the lesion does not tan with sun exposure. So if this person is exposed to a lot of sun and they tan, their skin gets tan and darker, but the lesion stays white and pretty obvious. Okay? And so superficial mycosis, hypopigmented or hyperpigmented lesions, the fungus involved in tinea versicolor or pityriasis versicolor, just two names for the same condition, is Malassezia species. There are a lot of species under this, not important for you to know. The only one you should remember is Malassezia furfur. Okay? It's a dimorphic lipophilic fungi. Lipophilic, it loves fat. So on the keratin, you have sebum, you have oils, and so it loves to grow there. And how to diagnose it is, for a lot of the fungal infections that we're going to see, you get skin scrapings, and then you scrape off the lesion on the skin, and then you put it in potassium hydroxide mounts. The potassium hydroxide is going to kill the keratinocytes and all the skin tissue, and the only thing that's going to remain is the fungus, because the fungus is resistant to potassium hydroxide. So you'll kill the keratinocytes, and only the fungus remains. And when you look at it under the microscope, you're gonna see a classic spaghetti and meatballs appearance. And this is it. So you can see the meatballs, these circles, and then you can see the spaghetti, which are these lines. Okay? So tinea or pityriasis versicolor is due to Malassezia furfur, and you see spaghetti and meatballs appearance under the microscope. Another way by which you can diagnose it in the clinic is something called Wood's light, which basically you shine fluorescent light onto the lesions and they will shine. Okay, so this is the same patient before and after the light. You see how when you shine the light on it, the lesions are so like bright. Okay, this is the Wood's light. But the one you should remember is spaghetti and meatballs on the potassium hydroxide mount under the microscope. Now the next one, what is the diagnosis? This is dermatophytosis, also called tinea, also called ringworm. Okay. Now, how does this look? First of all, dermatophytes, as we said, are the cutaneous mycoses. They're the ones on the right here, dermatophytes. Okay, this is how they generally look. In general, the rash will be a ring-shaped lesion, which is inflamed. So the border is red and the central is flaky. It has central clearing. Okay, so it just looks like you got a ring and you just, form the stamp of the ring. The edges are inflamed and red, and the center is clear. okay? And this is dermatophytosis. We have different types of dermatophytes. So dermatophytosis is the condition, okay? It's caused by dermatophytes. Dermatophytes are the fungi, and we have different types of fungi that fall under this group. Dermatophytosis is infection, is the skin presentation, okay? And we divide it based on where in the body it affects, okay? Before we go into the different locations, the fungi that are involved in dermatophytosis in general are epidermophyton, microsporum, and trichophyton. Again, these are cutaneous mycoses. They're not the same as tinea versicolor and malassezia. Okay. So epidermophyton, the first one, it will infect the skin and nails, but not the hair. Okay, and the way I remember this is when you think of the hand, okay, you think of skin, there's nails, and the hair on the scalp is kind of far. I know that hair is still on skin, but just imagine that the skin and nails are just with each other, and then the hair is just on its own, okay? So epidermal, when you think of epidermis, you think of skin. So just think of skin and nails, and the hair, is pretty far. And then the other one is microsporum. Microsporum infects the skin and hair, but not the nails. I don't really have a way to remember this. Just remember that microsporum does not infect the nails, and epidermophyton does not infect the hair. Okay? Trichophyton infects all three of them. So tri is three, so it infects skin, nails, and hair. Okay? These three are dermatophytes. They cause these infections. Now, this group of fungi are keratinophilic and keratinolytic. So they love keratin and they destroy keratin, they feed on it. Okay? How are they transmitted? They're transmitted by direct contact with the infected human, animal, or fomite. So, direct contact. And this usually spreads by using towels, sharing towels with someone, sharing clothes with someone who's infected. Yeah, so fomites, or as also direct contact with the human skin. And we have different types of these dermatophytes. They can be zoophilic or geophilic or anthrophilic. Um, Zoophilic is the one that's from animals. They get it with contact with animals. Geophilic is the one seen in fomites, so in clothes or towels. And anthrophilic is the one seen in humans. The one that's, chronically present in humans. So someone has just a chronic dermatophytic infection. All right. And the only thing you need to know here is that the anthrophilic one, since it's in humans and it's used to the human environment, okay, it causes a more chronic infection because it can stay there. It's used to the environment. But the other two, because they're not used to being in a human, they cause an acute infection and they resolve spontaneously. Okay. So now, as we said, this skin condition, which is caused by any of these fungi, can present in different parts of the body. And depending on where it is, we have different names for it. So this one, the patient has a dermatophytic infection on the beard. There's one over here, and there's one over here. So what do we call this? This is Tinea barbae. Remember, barbae is beard, so Tinea barbae is in the beard. And this is due to trichophyton. Okay. The next one is on the head, on the scalp. This is Tinea capitis because cap, just, imagine a cap, someone wearing a cap on their head. So capitis is for cap or for capitis for scalp. Um, And this is caused by microsporum and trichophyton. You will see that the microsporum is only present in Tinea capitis because remember that we said microsporum can infect the hair. Okay, so since it infects the hair, this is the scalp, there's hair on the scalp, so microsporum can cause Tinea capitis. And this is a chirion. Chirion is basically a severe form of Tinea capitis when you have a lot of inflammation and you see how red it is. So when you have tinea capitis that becomes pretty severe and inflamed, we call it a chirion, okay? Next, this is on the body. This is Tinea corporis, okay? Corp is, you know, when you say corpse, like someone's corpse, someone's dead body, basically. So corp is corporis, okay? It's body. So Tinea corporis is on the body, okay? And you see the same exact, the ring, the inflamed ring rash that we saw in the previous cases, you see it on the body, okay? Look how clear it is, the red border and then the central clearance. Tinea corporis on the body. Okay, next one. This is in the groin area. This is Tinea cruris. The crura is found in the around the genital area. So Tinea cruris affects the groin and the inner thigh. Okay, and it's caused by trichophyton as well as epidermophyton. The only exception to these, you're gonna see trichophyton in almost all of them, and as well as epidermophyton in most of them. The only exception was microsporum in Tinea capitis. This is usually where you would see microsporum. Okay. So we covered Tinea cruris, and then the next one is on the hand. This is Tinea manium, and man is the hand. So you can see on the hand here, this is a lesion, and then this is another one, okay? And Tinea manium is on the hand, and this is due to trichophyton. Now, again, same thing, but on the foot, what do we call it? This is Tinea pedis, okay? Because ped is foot. So Tinea pedis is on the foot. And this one on the right is basically when the Tinea pedis is more chronic. So this is how it looks. But then if it's a chronic infection and stays for long, you get hyperkeratotic skin. Okay, and this is what the hyperkeratotic skin looks like. And when it gets to that stage, we call it moccasin foot. Okay, so moccasin foot is kind of like a chronic form of tinea pedis, okay? So when you see the ring, it's very clear ring with the red in the border, right? Tinea pedis. And again, trichophyton, epidermophyton, just like most of them. And then the last one, if it infects the nail, we call it tinea unguium. Unguium is the nail, okay? So we know when we say onychomycosis, we're referring to fungal infection on the nail in general. Tinea unguium is a type of onychomycosis. So again, trichophyton, epidermophyton, just like most of them. So yeah, dermatophytes on the nails, we call it tinea unguium. Okay, and it's very important for you to know the different name for each location of this infection. So you know that on the head, on the scalp, it's called capitis. On the body, it's called corporis. On the foot, it's pedis. On the genital area, it's called cruris, and so on. And also know that it has to do with sharing towels, poor hygiene, just generally like poor hygiene and sharing towels. Okay. And how do we diagnose it? You get scraping from the skin or from the nails, nail clippings. You pull out the hair if there's tinea capitis, for example. You take scrapings from the scalp using toothbrush, so on. And when you take the sample, you put it under potassium hydroxide again, just like we did in the malassezia, to destroy all of the keratinocytes and only have the fungus. And you look at it under direct microscopy or under culture. You have some non-specific culture, which is seborrheic agar, which will be used in all fungal infections, and then the dermatophyte test medium is more specific to dermatophytes. But just remember potassium hydroxide. Now, which fungus is this? It's one of the ones that we talked about. This is Microsporum, and look at the shape of the macroconidia. It's cone-shaped. Sorry, it's spindle-shaped. So in these dermatophytes, we have macroconidia and we have microconidia. Macro are the big ones, and microconidia are these small, like dots. The macroconidia in Microsporum is spindle-shaped, and it has microconidia as well. It has both, but the microconidia is less than trichophyton. We will see in a couple slides. And this does not infect the nail, as we said, and it's very commonly implicated in Tinea capitis. Okay, Microsporum usually is only seen in Tinea capitis. Remember the picture, okay? The spindle-shaped is for Microsporum. Next one. This is trichophyton. So trichophyton, it also has macroconidia and microconidia, and you will see the macroconidia, they look more like pencil-shaped or elongated like this, and it has a lot of microconidia. In Microsporum, it has microconidia, but they're pretty little. They're not very abundant. In the trichophyton, it has so much microconidia. And trichophyton, remember, tri is 3. It infects the skin, the hair, and the nails. Okay? Know the picture. Again, pencil-shaped macroconidia. And the last one is this one. This is epidermophyton. It does not have microconidia, so just look at it. There's no microconidia, it's only the macroconidia. And the macroconidia are more like broad at the edge, like the distal part of it is more broad. It does not have microconidia, just remember that. And it does not infect the hair. The one in the hair is microsporum, right? And with this, we finish the fungal infections and we go into our last part of today's lecture, which is parasitic infestations. The previous ones were all infection. This is infestation because the parasite is just infesting, like it's just on top, okay? Now, starting with the first one, what is the diagnosis? This is classic scabies. So you see the burrowing of the skin, and it's caused by Sarcoptes scabiei. We're gonna go into more details now. So scabies is caused by invasion of superficial skin layer by Sarcoptes scabiei, which is varhomnus. Basically, it's a mite. Okay, so where is it? We have a picture for the mite in a couple slides, so we'll just come back to that point. But the mite, it goes onto the skin. Specifically, it's the female mite. Okay, so why female? Because it's gonna lay eggs. So the female mite goes onto the skin. It's gonna burrow into the skin, form these like tunnels. It's gonna go in. It's gonna lay its eggs, and the eggs are gonna release larvae, and then it just stays there and lays its eggs and lives its life. So the key is female mite of the Sarcoptes scabiei will infest and it will form tunnels. And specifically, where does it burrow? Into the stratum corneum, which is the most superficial layer of the epidermis. So stratum corneum. It's very superficial, okay? And basically, when it burrows in, you get these red papulovesicular rash, and it's very itchy. There's intense itching. And the reason for the itching is because there's a hypersensitivity reaction to the mite waste. So when the mite goes there, it's gonna lay its eggs, and it's also gonna put all of its waste products, okay, all of its fecal matter, and there will be a delayed type hypersensitivity to all the fecal matter of the mite. Usually it infects or it is infesting the interdigital webs, so between the fingers, okay, as well as in the palm and in the inflammatory folds and in the genital area. Anywhere where you have folds, okay, so between the fingers and in the palms. And again, there's very intense itching with the red papulovesicular rash, as we saw here, and tunneling in the skin. The tunneling, you can kind of see that this rash, there's like a line. Okay, if you look here, you will see a line. Okay, this is the tunneling. How do you treat it? You treat with permethrin, and permethrin is contraindicated in pregnancy, so in that case you would go for other options. But just remember permethrin. You can also use topical steroid for symptomatic relief to decrease the itch because it's hypersensitivity. So if you want to relieve it, you can use topical steroids. And how do you prevent it? Basically, it's transmitted by direct contact with a person who's infected or from fomites, so especially from bed sheets. So if you want to prevent it, if you find someone infested with scabies, you first of all you treat the close contact because they have very high risk of having it as well, and you discard the fomites. So you take the bed sheets that they were sleeping on and you just get rid of them completely to prevent spread of this infection or infestation. What do you need to remember here? Female mites tunneling into the or burrowing into stratum corneum, giving you this red papulovesicular rash with intense itching, and you treated with permethrin. Do you need to remember permethrin? Honestly, yes. I don't know why they like to ask about it, but I've seen it in a few questions. So no permethrin for scabies. And we're gonna come back to permethrin in the coming entity as well. So what is this picture? What's the diagnosis? This is nodular scabies. So it is a form of scabies. The first one here, this is classic scabies. This one is nodular scabies. It's more seen in children. And these lesions here actually are hypersensitivity reaction to scabies. So this kid probably has scabies, but the specific appearance, the nodular appearance on these specific areas, the trunk, the groin, the legs, which are not classically affected by scabies, this appearance is not the scabies itself. It's a reaction to having scabies. So this kid might have scabies on the hands, but when he has this rash on this trunk area, this is due to a reaction that this baby is forming to scabies. Okay, so if you take a biopsy of this lesion, you probably will not find the actual mite, okay, in the lesion, because this is not where the mite is, it's somewhere else. This lesion is just a reaction to having the mite in general, okay? It's not the mite itself forming this locally. So it's found in the trunk, the groin, the legs. What is this? This is bullous scabies, and again, same Sarcoptes scabii. This is more seen in elderly, so the nodular scabies, this one, was more in children. The bullous scabies is more in elderly, and the tricky thing in this one is that it mimics bullous pemphigoid. If you studied the bullous disorders, you would know that bullous pemphigoid has antibodies against the hemidesmosomes in the basement membrane. Bullous scabies forms the exact same antibodies as well, and that's why it gives you the same exact appearance, okay? So if you test for the antibodies, thinking it's bullous pemphigoid, you will find the antibodies. You won't think it's bullous pemphigoid, but it could be bullous scabies, okay? How do you differentiate if they both look the same and they have the same antibodies? You do a biopsy, and you look under the microscope or histology, and if you do, in bullous pemphigoid, you'll just find the findings of bullous pemphigoid. In bullous scabies, you will find mites, eggs, and scibala. So you're gonna find the mite, the source of the infestation. You're gonna find scabies itself, obviously. So bullous scabies and bullous pemphigoid, they have same appearance, same antibodies, but on histology, on histopathology biopsy, if you find the mite and its eggs and its fecal matter, this is bullous scabies and not bullous pemphigoid. Okay, and the next one. This is crusted Norwegian scabies. This is another form of scabies. It's specifically in immunocompromised patients, and it's basically scabies with hyperkeratotic lesions. Look how thick and like crusty and rough this lesion looks. It's the hyperkeratotic lesion seen in crusted scabies. This has minimal itching. Think about it. It's an immunocompromised patient. Their immune system is not that strong, so all of the inflammatory response that's going to cause itching is not as robust as in the other type, the classic scabies. So in crusted scabies, this hyperkeratotic, immunocompromised, there's very little itching, and because it's like very rough and crusty, you get these breaks in the skin and excoriations, and these excoriations, because they're breaking the skin, you might get a superimposed infection with Staph aureus or strep pyogenes. So because it's a, break in the skin, you can get superimposed infection. Okay? And what is this organism? This is Sarcoptes kbi, okay? It's the cause for all the previous ones that we were talking about. So how did we reach this? Basically, how do we diagnose it? When you see the rash that we saw in the previous pictures, you take scrapings of the rash and you put it under potassium hydroxide again, just like we did in the fungi. And basically, you would kill all the keratinocytes and you would only be left with these. You would find the mite itself, which is this one here, and you would find eggs. This is the egg, and you would find fecal pellets. These, basically the poop of the mite. So the mite, it's egg and it's poop, okay? And the mite is bag-like. I guess it looks like a bag. It has no antenna, okay? There are no like long antenna. And this is the egg containing larva, and this is the fecal pellets. So if you find this on skin scraping or biopsy, this is Sarcoptes kbi for scabies. Okay, now what is this? This is pediculosis, lice. So we're entering a new entity, and it's actually the last part of today's crash course, inshallah. So this is pediculosis or lice. Now, what is the difference between this picture and this picture? When we're talking about lice, we can break it down into two groups. The Phthyrius pubis and the Pediculus humanus, okay? The Phthyrius pubis is a type of lice that specifically affects the pubic area, the genital area, and it's due to it's a pubic louse. So lice is plural for louse. Louse is this organism, this parasite, okay? And this parasite that causes the lice, we have two types of lice, okay? There is the Pediculus humanus and Phthyris pubis, okay? Phthyris pubis is the louse that affects from the name pubis, pubic, okay? It's a pubic louse. It affects the genital area, the axilla, and the eyebrows. And it's an STI because pubis, so STI. And this is what it looks like, okay? So this is the Phthyris pubis. The other type of lice is Pediculus humanus. Pediculus humanus can either be capitis or corporus. Capitis, from the name, affects the hair on the head, the scalp. Corporus affects the body, okay? So now we have three types of louse: pubic louse, head louse, and body louse. Pubic louse is a group on its own. The head louse and body louse are a group on their own together, okay? This specific louse is Phthyrius pubis. This one is Pediculus humanus. They look different. Pediculus humanus is elongated, while the Phthyrius pubis is more round. It's called crab louse, okay? So this picture is pubic louse. It's crab-like, causes the STI in the pubis, Diphtherius pubis, okay? I hope this doesn't confuse you, but when you see this picture, this louse is called Phthyrius pubis, and it's a pubic louse, causes the STI. This picture, the more elongated one, is Pediculus humanus, and that's the name of the parasite. And we have capitis and we have corporus, two different entities under the same group. Okay, they both look the same. So capitis is the head louse that infests the scalp, and corporus infests the body, the trunk. Now, the key here is that the one in the head, the capitis, the head louse, is transmitted by fomites, and the other one is also transmitted by fomites or clothing. But the difference is that the capitis, you would see the nits or the eggs of this louse on the hair, okay? So the nits are the eggs, and you see it on the hair. Do you see the adult louse? Not really, because it's not very clear. It looks very similar to the hair, so it's kind of camouflaged. So you mainly see the eggs. But in corporus, you can see both. You can see the adult louse and you can see the eggs. And where do you see them? On clothes, okay? You don't see them on the body. Okay, so now just to recap everything on this slide, we have lice. Okay, lice can be two big groups: Phthyrius pubis versus Pediculus humanus. Okay, Phthyrius pubis is a group on its own. It is the crab louse, looks like a crab, and it causes the pubic lice. Okay, and it's an STI. And you see both the adult and the egg in the pubic hair. Okay, this is a group on its own. It looks different and it has a specific name, Phthyrius pubis. The other group, which is Pediculus humanus, is the one that can either infest the scalp or the trunk and the body. Okay, this is how Pediculus humanus looks. And if it's capitis, it infests the scalp, the hair on the scalp, and you see the eggs on the hair. You don't really see the adult a lot, mostly the eggs. And if it's corporis infesting the body, you see both the adult and the egg. Okay? Both of them are transmitted by fomites or clothes, in contrast to the pubis, which is an STI. The pediculus, these two groups, are by clothes or fomites. And a very important thing is that in capitis, the one that's on the scalp, the head lice, it only causes head lice. But the corporous one, which is on the body, it can cause the same parasite, the same organism, the same louse, can carry something. It can be a vector. Okay, so you know how you have some bacteria that need a vector to carry it around, like a mosquito or whatever. In this case, this organism can be a vector for Rickettsia provodzeki, which is a bacteria. Rickettsia provodzeki is the cause for epidemic typhus. Okay, so capitis, the head lice, the scalp hair lice, is only going to cause that. But the body louse, okay, the corporus, can be a carrier for Rickettsia provodzeki, can cause epidemic typhus. So it's more severe, okay? So when you have someone with the corporus, you need to make sure that they don't have epidemic typhus. Now, what is this? These two are different. So what is this one? It's on the hair. So what do we call it? So both of these are pediculosis. This one is the head louse, and this one is on clothes. So it's body louse. Okay, they are both pediculosis. They both fall under pediculus humanus, but one of them is on the head, one of them is on the body, but they're both pediculous. Okay, the pubis one is phthyrius. The head and scalp are pediculous, right? So this is pediculosis, the scalp and the body. This is on the clothes. Remember, it's not on the body, okay? The body louse is not actually found on the skin. It's found in the clothes. So if you want to look for it, look in the clothes of the patient. Don't look on their body. You won't find anything. And these are the eggs, okay? How do you diagnose it? Or first of all, how does it present? It presents with itching. So if someone has lice, they have a lot of itching in their scalp or in their body or wherever the lice is. And the cause of this itching is hypersensitivity reaction to the saliva of the parasite, of the pediculus or the phthyris. Okay, so itching and excoriation. So from like if they keep itching, there can be excoriation of the skin, and yeah, so pruritus, excoriation. How's it diagnosed? It's a clinical diagnosis. If you look for the lice on the hair, you'll see it. This is lice. It's not really rocket science. But you can do the NITS fluorescence under ultraviolet light or Wood's lamp, which we did, remember, in which condition? In the tinea versicolor for malassezia furfur. But this is only done to screen during outbreaks. Normally, you wouldn't need to do this. You just rely on clinical diagnosis, but you can do it if you are suspecting an outbreak in a big group of patients. So you screen all of them with this light, and you take the ones that are positive in the screening and you treat them. How do you treat them? For the head louse, the lice on the scalp hair, you give them permethrin, which, if you remember, we talked about this also in scabies. Okay, permethrin. And you also use a fine-toothed knit comb. So use this comb, you comb through the hair, and you basically you get all of the lice and all of the eggs out. And yeah, so permethrin and the comb, okay? Now, if there is permethrin resistance, you would use ivermectin, okay? But remember permethrin. Please remember permethrin. It seems like a low yield point, but just remember it. Now, this is for head louse, okay, on the scalp. For the body louse, which we find the eggs in the clothing, okay, you need to discard the clothing, or you need to wash it in above 60 degrees Celsius, okay? Now, an important thing, remember that we said that the body louse, the specific one, corporis, can be a vector for Rickettsia prowazekii, which causes epidemic typhus. So when you're treating someone with body louse, you need to make sure that they don't have epidemic typhus, okay? So you don't really need to treat it. If they don't have epidemic typhus, they just have the body louse, and you discard their clothing, everything is on the clothes. Remember, they don't have anything on their body, okay? The egg, the adult, everything is on the clothes. So if you discard the clothing, they're fine. You treated them, okay? You only need to treat if they have an underlying Rickettsia prowazekii due to this infestation. Okay, and with that, we conclude today's crash course for micro. I hope this helped you guys, inshallah. Inshallah, it's comprehensive. Um, and yeah, I hope you benefit. And if you need to reach out at any point, you have my email, you have my phone number. Please feel free to reach out. I'm happy to help at any point. And please scan the QR code if you'd like to give feedback so that we can improve. And thank you so much for watching the recording, and I'll see you in the next spell session, inshallah. Bye.